Okay, we are back, and we have a patient perspective. Wes Helms is going to be speaking, and then we'll move into Q&A with Brian McGeeney. Dr. McGeeney will facilitate that. Eileen will make final announcements. We'll take a break, and those who are going to join us for the evening reception will come back at about 6:45. So Wes is our, as I mentioned, is our last presenter of the day, and he'll be talking about his experience from the patient's perspective. He was 22 when he had his first attack. That was about 6 years ago. After successfully breaking a cycle with psilocybin, Wes developed an interest in advocacy, and he's been advocating for increased awareness of the condition, increased funding for research, and for the approval of the use of alternative treatments. So Wes, why don't you get started when you're ready? And do you want to answer questions, be interrupted to answer questions, or do you want to wait until you finish?
I can just go through, I'll just go through my speech, and if everyone can hold the questions until the end, that'd be great.
Okay.
So my name is obviously Wes Helms. Wes Helms is pretty much what everybody calls me, Wes. I started, my story actually starts around the age of 11 when I started having pain at the base of my skull on the right side. Never had attacks, but I went to the chiropractor, did physical therapy, you name it, you know, acupuncture, and after a few months, the problem did resolve. Looking back, that was probably the start of things. And I went years without having any problems until the age of 22, when the headaches became severe and they started happening multiple times a day. And they developed into what we would call cycles. I had no idea what they were at that time. I wasn't seeing a neurologist. I did get MRIs done. We went to the ER a few times. All the tests came back normal, of course. And it wasn't until the age of 24 that I began a cycle. I did use psilocybin to bust. And then I had another cycle 2 years later when I was 24. That was actually when I met my neurologist, my home neurologist, Dr. Pico, who is absolutely amazing. I have his cell phone number. I can call him at 2 in the morning and he'll answer. He's an amazing doctor. I think we were talking about doctor-patient relationships, and that's a key factor. I don't think I would be where I am now without him. But he did start me on the normal, you know, verapamil, lithium. You know, we tried pretty much everything, and it ended up that a prednisone taper and psilocybin ended up busting that cycle at the age of 24. Got some mushrooms from a friend. I continued having headaches sporadically until 2016. And in 2016, they became it became more difficult to keep them away with just psilocybin. And I did start taking lithium every day. And I have used lithium multiple times for cluster headaches. I'll admit that to anyone. You know, I don't care if anyone really judges that. It works for me. It has multiple times, and so has psilocybin. So I know that they both work. Since then, you know, I went 2 years pain-free, 2016 to 2018. pain-free on lithium and verapamil, the chronic cocktail. And in 2018, I began having a cycle that was about 4 months long. It was horrible. 8 attacks a day. One of those cycles that you're wondering whether you're going to actually live or die. Nothing's really working. I was trying to bust and nothing was working. And I finally, it took a few high doses of psilocybin, some prednisone and lithium, all mixed together kind of to break that cycle. But what I was left with was this constant pain. And I thought it was a shadow. I thought it was a strong shadow, and I was telling everybody about it. This is when I became very, very involved in the group. And I started speaking out and saying, look, I'm not having attacks anymore. I'm having this cluster-like pain that's right here in my eye, in my temple, and at the base of my skull, that just lasts all the time. I mean, it just roller coasters. It goes up and down and up and down. And nobody could really figure out what it was. This is obviously, when I became involved and started meeting a lot of people within the groups. And I realized through trying many medications that this pain was most likely not a shadow, but it was something else, another headache condition altogether, but possibly still related to my clusters. So I lived every day in utter pain, every minute of every day. 2019 was probably the worst year of my life. I went to the ER more than 10 times. Doctors just shrugging their shoulders and giving me pain meds and doing whatever they could to just get me comfortable. And I was lucky enough to actually meet Dr. McGeeney and go and see him. Great doctor. I was able to get my hands on some ketamine, and that did stop the high level pain. I'm an advocate for it. I will tell you right now, it will halt a strong attack. But it wasn't doing much for this constant pain. And so this constant pain, I can't snort ketamine all day, so this constant pain was just still there. And my local neurologist obviously was trying to help me with this, and every day it was just pain. I was getting nerve blocks. I'm staying on prednisone, taking too much of it, obviously, just because of the fact that it was hurting all the time. The past year was especially bad because I thought about taking my own life. I know that I've talked to Ainsley and a few other people, and I would like to personally thank Ainsley and Eric Cohen and Eric Diamond and a few other people that have helped me when I was at my worst. And I was admitted into the hospital, obviously, and evaluated. I went there willingly. And that's just the low that this pain brought me to. It wasn't because I wanted to die. I love life. It was just because I was in so much pain. And so that's how low it brings you. We talked about whether it could be chronic migraine, hemicrania continua, which is another trigeminal autonomic cephalalgia. But the one that really stood out was occipital neuralgia, because it dealt with this pain at the base of my skull, and it kind of spread up, and then also affecting this area right here. And I kind of took a leap and decided to go with a trial for a occipital nerve stimulator. It was a trial of 4 days, 4 to 5 days, and you would be able to try it out basically. And if it didn't work, you don't get it. And if it did work, you get it permanent. You get it put in permanently. So that's what I did. I went out to Dallas, Texas, and me and my mom and dad all drove, because I didn't want to fly because I was scared of getting an attack. We drove all the way from North Carolina to Dallas, Texas, to try this thing called the Reed procedure, which is an occipital and peripheral nerve stimulator. There's a lead going up right here and a lead going right here, and it actually helped with the constant pain. It helped tremendously. So I got it permanently put in, and and I have it in right now. Right now it is stimulating the supraorbital nerves right here and the occipital nerves in the back. Since then I've been a whole lot better. I haven't had any attacks, true attacks. I might have had 3 or 4 attacks right after the surgery. It's almost like the anesthesia triggered something. But I did have some attacks right after the surgery. But after that, I've been great, and everything has been, a lot better. It's not perfect. I still do have pain, and then I can turn up the stimulation a little bit. But that's how I treat my occipital neuralgia. Now, that will do nothing for cluster headaches. If you have a cluster headache, what I have in will do nothing for a cluster headache. Cluster headaches are just too strong and too painful. So I've began, using CBD to treat my constant pain. And if I have another cycle, if I go into another cycle, I will use psilocybin. That's my plan. But yeah, if there's anything that I can say, that's where it started and up until now. And if there's anything that I can say, it's that I use lithium, I use verapamil, the chronic cocktail. It's not great for you, but it works for me. I use psilocybin. I use the D3 regimen, and I'm significantly better with the implant. So if there's anything that I could tell anybody listening, it's don't let people judge you or change your ideas of what might work, because everybody's different. And there's a lot of people in the Facebook group, if you post something, that are going to shame you and judge you for what you're doing. And I don't think that that's right. And if anything, the treatment bashers should hold their tongue. That's the way I feel about it. But yeah, so I guess that's pretty much my story. That's me. That's where I'm at. And if anybody has any questions, I would love to answer them. Okay, so.
Sorry, Wes. I was starting to speak and realized I didn't have my volume on my.
No, you're fine. You're fine.
I was still muted. But I wanted to say that, like you, I had my first attack at 22, and like you, I'm only 28. Yeah, yeah, right. So that was 36 years ago, and I identify very closely to the hopelessness and helplessness you described, as I think probably many, if not all of us do, and want to commend you for being so open about your experience, and also for emphasizing the need for all of us to be open-minded with regard to the choices others make. At Cluster Busters, we think it's important for people to make their own decisions regarding their treatment and what works best for them, and for others not to judge them harshly for the choices they make.
Absolutely.
Yeah. So with that, do you want to scroll through the chat and answer questions?
I see a few questions. So I can show you where the implant is located, Tom. There's a scar on the back of my neck. I don't know if you guys can see it or not. Hopefully you can. That's where they put it. And then there's a battery right there. And there's wires that run up to the stimulator. Let's see. The surgeon in Texas was Dr. Kelly Will. The procedure is called the Reed procedure. And yeah, of course, I was definitely called a drug seeker because of how young I am. Every time I would go to the ER, they would call me. They would label me a drug seeker, give me the migraine cocktail, Toradol or whatever, and that was fine because it, sometimes it worked. All I wanted to do was get out of pain. So, but yeah, I even went to a psychiatrist once who said, no, you're just here for, met or like Xanax or something, and I walked out. So I've definitely been called a drug seeker. Who diagnosed me with occipital neuralgia? That would be my neurologist, Bernie. That would be my local neurologist. His name is Dr. Pico. And it's just basically this constant pain that's kind of at the base of your skull or at the base of my skull that kind of radiates pain up the right side, which is my cluster side. It radiates pain up the back of my head, kind of right there, along the third occipital. Really, it's like it's in the middle, so yeah, that's those were the symptoms. It would be kind of sharp pain, electric, sometimes dull, sometimes just you want to wrench your head off, basically that's the way it feels. How is my sleep with the stimulator? Oh, it's fine. I sleep great. I sleep probably a lot better than I know. I sleep better than I did before because I'm not having the pain at the base of my skull all the time. It's actually it's doing something. It's rerouting the pain signals or doing something because it's just massaging that area. That's basically how it feels. The stimulator feels like a gentle massage. So to charge the battery, there's actually a thing that uses radio frequency, and you just put it right here, and you can hang it over your head, and it just kind of hangs right there. You can watch TV, and it takes about 2 hours to charge, and then it'll last for a week or more. I don't know of any other hardware that was contraindicated. I do know that there would have to be a special MRI. They said that I would have to get. I can't because of the metal that's in my body. But all my MRIs have come back normal, anyways. I'm pretty sure that I don't have a tumor. But if I ever got one, then I would have to use a special MRI to see it. You could always use a CT scan. CT scan is fine with this. How often do you have to go back to her office? So the battery usually lasts about 5 to 7 years, is what they said, something like that. And then you would have to obviously go back, and he would just cut your clavicle, cut that pouch open, and replace the battery. But that's a small price to pay for not being in pain every day, for me, at least. Thank you so much, Vera, for commending me, saying that I have courage and strength. I appreciate that. So I've tried to switch it off, and the pain comes back pretty much immediately. Within the next few hours, the pain comes back, and I have to turn it back on. Yeah, so it's pretty much on all the time, Dr. McGeeney. Yeah. So a cluster attack is still horrible, even with the occipital nerve stimulator. Like I said, that I have occipital neuralgia or whatever. I don't really care what it is. I just know that this stimulator helps with it. I'm pretty sure it's occipital neuralgia, but a cluster headache, the stimulator does nothing for a cluster headache. It might help a little bit with the nerves, but cluster is more kind of, it's a whole nother category. Yeah, I still play golf. I just played the other day, but sometimes it's hard because it wears me out, and I'm moving around, and I'm still getting used to the stimulator. I've only had it. I'm going on 7 weeks now, so that's I haven't had it very long at all. Yeah, I would love to join as a panelist. Metal detectors, I can go through them. I just have to turn the device off. But I can go through metal detectors at the airport. That's fine. All right. Is there any other questions that I missed to clarify? Is it not for cluster patients? No, the occipital nerve stimulator is absolutely not for cluster patients. If you have cluster headaches, it will do nothing for them. This is for constant nerve pain. Did I find it hard to be taken seriously by doctors? Absolutely. Yeah. You get this is in your head, and it's not hurting all the time. It can't be hurting all the time. Cluster headaches aren't like that. They put you in that cluster headache category, and then they think that they're 1 to 3 hours long, and that's it. And they don't believe you that you have this constant pain that's going on in between attacks. I do have concerns about banging my head during a CH attack and damaging my device. Absolutely. That's a great question. I even have concerns about being punched or something in the chest. I don't think that would happen, but hey, never know. But if I get punched in the chest and it destroys that battery, then that's another trip to Dallas and another surgery. So, yeah. I usually don't bang my head against stuff during an attack. I'm a rocker. I rock back and forth, just like this. Oh, Anna, trigeminal neuralgia is a horrible condition. I'm so sorry. And migraines, that's got to be hard for you. Thanks, Eric. Thanks, guys. I really appreciate it.
Thanks so much, Wes.
Thank you.
We're going to move into question and answer portion of the day.
For the question and answer, Brian McGeeney is going to kind of be our host. Thanks for coming back. I have promoted to panelist most of our speakers. If I missed you in the participants and you'd like to be promoted to a panelist, please just give a shout out and we'll get you up there so that all of our speakers who have been talking during this can answer any further questions you have. So it's pretty much just an open session. Let us know what you want to know. What haven't we been able to answer yet that you want to hear about?
I just want to check my microphone. Everybody can hear me okay?
Yep.
All right. I've been asked to moderate. So I can see in front of me all the comments on the right. And first of all, I have to say, Wes, that was outstanding, and thank you for explaining that. I mean, this is like the cluster headache of cluster headache. Not only do you have CH, but you also have this hemicrania continua type problem. That was the main problem for you, and thank you for making the distinction, which is extremely important, between cluster and what you have. Because the overall headache medicine has been relatively underwhelmed by the interventional stimulator procedures. When you take everybody into account, the results aren't that great. And you really, really, really needed some benefit by the sound of things.
Yeah, I was at the end of my rope.
And because ordinarily, somebody having, say, an occipital stim like that for cluster, I don't think it's that useful. Maybe there have been people listening to us right now who have, I see a question or two on Emgality, but anybody have an occipital nerve stim implanted who's willing to acknowledge? Let's see. But anyway, if not, you can always comment at a later time.
Cluster, it just doesn't work for cluster, for attacks.
Well, you know, there are plenty of things that the kind of consensus it doesn't work, but they end up having anyway, for one reason or another. We spoke, I think, 2 days ago about the microvascular decompression and craniotomy with your head split open, which is designed for trigeminal neuralgia, but the occasional neurosurgeon will do that for the cluster head in desperation. Now, I'm asked by Anne Williams about Emgality. Thoughts on Emgality? Can you verify episodic only? Take it during their cycle. Also, what is your thoughts on a chronic cluster and taking it monthly at 300 milligrams? It's something we did touch on Thursday, the session on Thursday evening. The indication is for episodic only. From one clinical study where the outcomes were modest, but definite. And it failed in chronic cluster. I also made the point that I do have at least one patient who's chronic and responds. And by responds, it means it switches the attacks off. And then it bubbles up again in 2 to 3 weeks. And they have to wait for the next injection. So that's a continuous dose, redose evidence of effect, which is a bit different to migraine. But it is 300 milligrams. That's the indication. They had one shot. Lily had one shot at suggesting a dose. Um, and so the trouble with chronics that if it, the insurance company may not pay for it if they know you're chronic. So in a letter of necessity, I would ask for cluster headache and not specify chronic. It's much less likely to work. Do not have great expectation. You're looking for big outcomes. Remember, if you're not sure something is working, it ain't working. And so any other, I mean, I have topics and questions as well for the folks with the disorder, but it's a pity we can't bring any questioners on. Is welder's oxygen safe to use in place of medical oxygen? Very topical, and Bill Mingus is an expert in that. I can say my piece, but maybe the oxygen expert wants to take that one.
I've been to an oxygen supplier and they fill them out of the same big tank. The difference is in how they vacuum the medical tanks. If the welder's oxygen isn't pure, you're not going to have good wells and nobody's going to buy your gas. So I feel comfortable with it, and I know many people do. That's a determination you have to make for yourself.
But I think that, wouldn't you agree that unlike carbon dioxide or other gases, it has to be relatively pure, otherwise it can go bang. So they have to, it has to be, there's no additives like with CO2.
Right. As far as I know of.
And if you own your own tank, then you won't suffer the jeopardies of getting a different tank every time.
Yeah, I would recommend buying one if you can afford it. You can rent them, but I personally would buy the tank, and that way you know where it's been, how it's been used.
Yeah. I mean, so there's a lot of experience, unfortunately, in desperation with welder's oxygen. There's Tom Shelton asks about verapamil. Should I take it year round or just right before I know I'm going to have them? So for the episodics, it's probably, in my opinion, best to wean down and off weeks after you end your cycle. I think that the body is more responsive to it when you go into cycle again, when you restart it, as opposed to keeping it up and going. So the hit to the body of verapamil newly started might be better. Now, there is no evidence-based medicine to back up that. It's a hunch. But most physicians encourage. Now, the occasional patient doesn't want to totally stop it. And I totally understand that. But at least to taper down a bit. And this is by convention, I will admit. There's a question, is it possible that carbon monoxide exposure might play a role in cluster headache? Well, I know an answer to that. It's a little complex though. So carbon monoxide, so that's the toxic gas that can be a product of combustion, comes out of your cars, vehicles, among other things. And it takes the place of oxygen in hemoglobin, and it can lower your ability of blood to carry oxygen a little bit, but that's important. And that's where the issue is. Because if it does that sufficiently, it may be, in fact, presenting a little less oxygen to your body, and possibly that may be a trigger. But it's not certainly an explanation for why cluster headache exists by itself, or for the great majority of people having attacks. It's a theoretical concern in somebody with a big exposure. Hopefully that answers your question. Joe, is it? Oh yeah, it's and it's only going to be, it's not going to make the disorder worse long term. It's only going to be a possible trigger there and then, and that's it. And we're asked, can anyone suggest a regimen for using LSD dosage and frequency? I mean, I can although I can tell you what I've heard, maybe there's somebody else on the panel want to answer that. Emmanuel, who had spoken a lot about the psychedelics. Do you want to hazard an answer on that?
I would actually defer to those who've actually had some experience with it. I haven't used LSD since back in grad school, and I gave it to rabbits. So, so I can't. I don't have that same experience with human use. So maybe someone else could speak to that.
I mean,
I can, unless somebody else wants to. So that's what I use. When I started using alternatives, I began with psilocybin, and that was effective for a while, and then it was no longer effective. So I switched to LSD, and so I use it the same way. I take 1 microgram, which is one drop of full strength on a small piece of paper. 100 micrograms, I'm sorry, 100 micrograms on a small piece of paper, and sublingually. And right now I'm using it about every 5 days. I've been using it for the last 2 months because I feel a great deal of activity on my affected side, and I'm using it prophylactically. I'm like right on the edge of a cycle date. So historically, I start right around this time of the year, and so I'm trying to ward it off. And in between cycles, I have dosed about once a month at a lower dose, maybe a half tablet, 0.5. No, I'm sorry. Wait, what am I talking about? 50 micrograms.
Yeah, I would say 50 micrograms is a good place to start if you're a little nervous about it. Yeah.
Yeah, I mean, the experience is going to be different for each person, but I haven't had like an extreme adverse experience at 100 micrograms, but I agree. I think 50 is probably a good place to start.
And Eileen asks Dr. Burish in connection with the usefulness of identifying. Can you see the question mark? Okay, we'll just switch your audio on. Yeah. Do you want to answer
Sure.
that question?
So, question about the cluster headache is one of the worst pains someone can experience.
What's the value of us trying to frequently talk about this as the worst pain experience? What's the value in that?
Yeah, so I think a few things. One is education and advocacy. I think trying to get that across to people who don't understand it, obviously not the people at this conference, but to people who don't know about cluster headache. It can help kind of raise the awareness for physicians. It's about the urgency of this. You know, it's not a, I'll see you in a month kind of thing. It's, we had this kind of email chain going across one time about how often, when's your next new patient appointment? And they'll say, oh, it's 6 months, it's a year, unless you have cluster headaches, and then it's this week. And that's kind of, trying to get that through to other headache docs, and headache docs, but other docs in general is important. I think that's important. We were hoping to find some correlation with certain medications or things, but we didn't find that. And then the other part, do you think this will minimize other pains? We talk about this a little bit in the paper, which hasn't been published yet, but there's a difference between this type of pain. We don't want to minimize others. For example, migraine may be less intense on average, but it's much longer. And so you're dealing with a less painful thing, but for hours and hours and hours at a time, all at the same time. And so there's, which is the worst versus, for us, it's the worst pain intensity, but that may not be, duration or how often or, those types of things are different.
All right. And Elizabeth asks us to comment on vitamin D, the D3 regimen for 8 years she's been on. Is it safe long-term? I can throw my piece in and say, as far as we know, yes, as long as you don't go clinically toxic. It's worth looking into this more, and I plan to do that. So on the very long-term high dose, we touched on it on Thursday evening. And there's clinical data, and some clinical data of as much as 10,000 a day for 6 months or 5,000 a day for a year in the literature, but we're using doses far in excess. And does anyone, if any of the board wants to comment on that from a long-term point of view, I don't even feel as much of an increase in kidney stones, but I can't exclude that. And that's a sort of thing that grows over a long period of time.
Hey, doctor.
Yeah.
As a person who deals with chronic kidney stones, and I've been on the D3 regimen for a very long time now, my kidney stones precede it. My kidney stones actually were more close to Topamax and zonisamide use than it was D3. I have had long discussions with both my urologist and my neurologist and other physicians about going on to D3. And the big thing was that calcium level, which you talked about.
Yes.
Just making sure that stayed within normal ranges. And if it moved up a little, we were going to have another talk. So I think long term, most of my doctors all agreed it was okay, even with my kidney stone issues.
Yep. And another question for Dr. Schindler. What are the ideal conditions to try psilocybin mushrooms? And lying down, eyes closed with music, or lying down, eyes closed, no music, no stimulation, staying awake, and or driving fast on a highway? No.
Maybe riding a bicycle, right? Yeah, so in the studies that I've been doing, I wasn't trying to accentuate or to minimize psychedelic experiences during the sessions. It was actually sort of person by person. Some people found it more calming to not listen to music. Some people wanted music. Some people watched movies. I had one patient watch Harry Potter, a couple Harry Potter movies during their session. Some people wanted to walk around a little bit. Everybody was a little bit different, and we were there to help them out in however they felt comfortable. And again, because there's probably a separation between the psychedelic effects and the treatment effects, then I think in terms of using psilocybin mushrooms for treatment, the information we have right now is that you don't necessarily have to try to accentuate the psychedelic effects. Just be comfortable. In my own patients who have told me that they use psychedelics for cluster headache or for migraine headache, I always tell them to make sure that they're with somebody so that they're not by themselves in case they do have some anxiety. So that I would also just say that.
And I would say that, see, the conditions they were in for your study, they were in an unfamiliar clinical environment, whereas one tends to foster being in a familiar environment, quiet environment, and often patients, subjects, I should say, or even look upon music as being a great comfort or can help keep you on the even keel, so to speak, and stuff that you like. And it keeps the mind from wandering aberrantly. Would folks agree?
Yeah.
All right. And then Tony is bringing up the topic of oxygen again. We can't get welders' oxygen in Finland. There's no welding in Finland. No. It's super difficult if you don't have your own welding business. Diving gear is easier, but even that you need a permits and a license. We do have fairly accessible medical oxygen if you can manage to get an oxygen prescription, which is difficult. Wow. Oxygen tanks cost around $250. That's every refill or a new tank. You can imagine how financial gain may affect things. So I wonder whether the general medical coverage in Finland covers that. Possibly not fully, because you're able to quote the price. And that's a comment. And then Paula asks about 10 milligrams daily of prednisone. Will it prevent full busting effect of psilocybin? Well, the answer is it may. We don't know for sure. It may. If you take that for long enough, as I always say, one will start looking far too close to a chipmunk than you want to. So the steroids should be brief. But your question is it going to blur or limit the possible effect of psilocybin? It's always good practice to stop it as much as possible. And that's a dictum, a safe dictum. We don't have evidence either way. A board, if you want to comment at any time, feel free to jump in on this. We just don't know. It would be better to not have it. To give you an example where things can really go wrong. If you're on a high dose of steroids, it can make you somewhat emotional or extremely anxious. And you don't want to add these powerful agents on top of that. That's a nightmare. Now, 10 milligrams is not so likely to do that, but it might, depending. So I hope that answers.
I will interject and say that I have taken prednisone with psilocybin
and you've got the outcome you're looking for.
Yeah, on the tail end of a taper at the lower doses. I have done it, and it didn't really hurt me at all or anything, but yeah, I don't think it's too big of a problem.
Yeah, I hope that answers the question. Next question. Wow, what a comment. My dad as a child was in a concentration camp, a survivor, but his head was irradiated numerous times as a treatment for head lice. He suffered cluster headaches since. He's now gone. But as a nurse, I'm curious, is there a possible connection? Well, radiation to the head can cause various neurologic abnormalities, even long term. We don't recognize cluster headache as being one of those. We recognize radiation therapy can affect peripheral nerves and more commonly, but it usually doesn't present like a paroxysmal pain, a lightning type pain. So it's probably not, but who knows what else he was exposed to that you don't know.
I just wanted to add to that because my patients are all veterans, and some of my veteran patients have been exposed to various toxins, and I have a couple of patients who develop cluster headache after exposure to, for instance, jet fuel or burn pit smoke, where their attacks began shortly after exposure to those. So I think that there are lots of possible stimuli out there that we're not aware of that might set off. But yeah, specifically radiation I'm not aware of, but I've heard of some various other stimuli.
So Emmanuel, are you in a position where you're asked to make document the likelihood of these exposures triggering the cluster or causing the cluster? Do you have in your practice, are you in situations where you have to, as a matter of record, make a comment on that?
Sometimes, yes. Yeah.
Okay. That's difficult.
Yeah, it is difficult because you don't know what else was going on. A lot of the veterans have head injuries or blast exposure as well, so you can't say whether it was the blast or whether it was the jet fuel, but it was probably related to their service in some way. But it can be hard to really say, yes, this was the cause of it. But we're seeing a lot of different types of, while most post-traumatic headaches are of the migraine type, there are various forms, including cluster.
And Dan asks, would 450 milligram capsules of mushrooms, that would be about 1.7 grams, be enough for a 270-pound guy to bust on the 5-5-5 schedule? Thanks. I don't know if he'll need a little more. Although I could answer that, maybe the other folks on the board should make a comment on it. Anyone want to jump in with the dosing? That's about 1.7 grams. Dry mushrooms, I presume. Dan?
Well, This is Andrew here. I mean, you can always add more later. We always recommend that you start with something smaller. Everyone reacts differently to it. I'm a larger guy myself, so I do typically take, you know, a couple grams to bust, but that doesn't necessarily mean that's where you have to start. Usually, if you have any concern about the anxiety or any side effects, you can go ahead and start with, you know, a half a gram. And then, you know, you can always take more.
Yeah, I did it like that as well.
At 270 pounds, I think you don't have much to worry about 1.7 grams. From a safety point of view, from a medical safety point of view, that I will comment on. And the next question.
Ryan, Bob wants folks to know that everyone's brain weighs about the same. So,
but it's the dilution.
It's probably fine. Yeah.
It's the dilution. And that's different. So it's the concentration that gets into the brain. Next question I see. You may, verapamil worked great for me for the first time, and this is Tom. I took it, worked to reduce the pain level and duration of an episode. It cut everything in half. So I continued it after my episode was over. And when my next episode came 10 months later, it didn't help at all. Well, this is unfortunately not uncommon in medicine. Things work the best the first time and not quite the same. I'm sure most people have had that experience or have known somebody with this sort of experience. Such and such works great the first time. My course of steroids, great the first time. After that, maybe not so good. So it doesn't surprise me at all, unfortunately, Tom. Anybody on the board want to comment on that?
I've had that experience. The medications, I've taken countless medications over 30 years and prescription medications, and they seem to work and then they don't work when I try them again. And it's hard to know. I've never really determined whether or not the medications were effective or I was coming out of a cycle organically. So yeah, it makes sense to me that the medication, this person might have a very different experience the second time taking that medication.
Well, and
go on.
I can speak from a chronic point of view that it seems to happen that things will work for a while and then it won't work. And that's one of those things as a chronic, you know, you're not coming out of a cycle. It seems to work for a while and then sometimes it doesn't. So I think it's pretty normal for things to sometimes work and then not work later.
Yeah, I experienced that a lot in my time. You know, for those who don't know me, I'm Andrew. I started when I was 12. I've been chronic since, and I'm 28. So yeah, it's really unfortunate, but that was something that happened very commonly for me. Things that did work, sometimes quickly, sometimes not so quickly, but they would inevitably stop working if they did work. But that's also something we like to talk about. You know, especially with oxygen, things like that. If it's something you've tried and it stops, and it's something that's safe to circle back to, it's okay to try those things again. So don't be afraid to retry something. Of course, with the prescriptions and medications, you want to consult your doctor. But if you're talking about oxygen or something like that, always be willing to retry something.
And to avoid people just getting too disenchanted, I often say that all you need is two things that work great temporarily, and you can just flip between them. You don't need something to work forever. You need a couple of options that work for a while, and even better. And I have a comment from Tony. Tony, you can message me personally on Messenger or some other way, or I might try and reach out to you later. And Tom, again, what dosage about the verapamil 3 times a day? Well, I mean, I often start on 80 milligrams instant release 3 times a day, quickly going to 160 3 times a day. And after that, you kind of, to push up, it's a good idea to get an EKG and go up as tolerated, or as much as the physician feels comfortable with. That's kind of a gray area. You know, how much do you push it, especially if the patient isn't responding? And the quick answer that physicians have often is, well, you just keep pushing it up. Yeah, well, that's nice to say, but when the patient can't stand upright due to the fall in blood pressure and they're so constipated they haven't passed a bowel motion this month. You know, I mean, it's probably best not to be on it, but you have to give it an honest try. Next, I'm a chronic cluster person. The D3 topic has come up several times during the conference, and I'll be discussing it with my headache specialist next week, doing Batch's latest version of the regime, which include periodic lab tests. Yes, it better. I have read many positive comments on this and was wondering, is Dr. Me or would like to comment further? Well, it actually came up a number of times throughout the whole meeting, the D3 regimen. And you see, we don't have evidence-based medicine that it works. When you don't have any evidence-based medicine, you have to go with anecdote and personal experience. And it's a fraction easier trying to decide whether something works in cluster because of the uniformal severity of it. It's worse, it's harder, much harder in migraine. But when you hear people with chronic switch off temporarily to D3, that's pretty impressive. You know, some of you may know a patient who took over 1 million, close to 1.5 million units in the one go. After, I think, failure on lower doses. Now, he did that and then didn't take it for quite a while until his level came down. Did it stop his chronic? Yes. I'm not advocating that. But the fact that it could do it at all tells you something. And we need to look more into this. And it includes, from our point of view, looking at more of the safety of really pushing the numbers up.
Wow.
Anybody want to comment? I can comment more, but feel free to anybody on the board. You see, so that sort of thing, it either works to some degree or it doesn't. And the fact that it can switch some people off, it appears to be related. I mean, causation is always an inference. So you always best guess a causation of whether, I don't doubt that he took that dose. I don't doubt that he stopped the attacks. The question is how related they are. I'm going to move on unless there are any other comments. There are loads of comments, and that's fine. Keep them going. Suggestions on how to deal with the fear that comes with awaiting the next cycle or headache. Yeah, and that's really for the cluster heads. How do you deal with the anxiety of anticipation, the anticipatory anxiety, which can easily roll into catastrophe, the feeling of catastrophe, and there's no ending. Anyone want to comment on that?
Yeah, well, I personally never had that so much because when I get an attack, I basically have the idea that I press on the pause button, so everything stops. I don't think about it. The pain is there, but I don't try to be bothered by it. Maybe sounds bad. And then after an attack, I just press play, and then life goes on. So I try to block that in my mind in a way.
That is a desperate thing. I don't know how people they go to sleep knowing that they're going to get clubbed in the head.
I think
yeah, go on, Mark.
Well, I think that what we're talking about overall is the post-traumatic stress aspect of this, having this disorder, I don't know. I've had it for 36 years. I don't know how to deal with it. I'm upset all the time. I'm worried, and I'm in a state of anticipatory dread. I feel a tingle, and I feel really panicked because I know that the tingle means that I'm about to go into a cycle. And once the cycle starts, my life stops. It's not that my thinking about it stops, my life stops. So, and then I'm many of us experience this. The pain is so,
yeah.
I mean, it's just indescribable, really. It really is.
Yeah. one of the ways is to really to optimize your therapy as much as you can, arm yourself with as many weapons against it as you think are useful. And so when you would tip the balance, otherwise it'll eat you. So if you've identified what, go on.
I'd like to comment on that as well, because I often tell people as a chronic, I used to be episodic. I'm very much happier as a chronic because I don't have those times of anticipation. I have to be honest with you. I don't have a good answer for how you deal with that anticipatory anxiety. I say the best things you can do, obviously, is be prepared at all times for your next attack, and then live your life and try your best to kind of hit that play button. Like I think it's Rozier said. I wish there was a good answer there, because I think that's one of the really awful, hellish parts of episodic crustal headaches that people don't talk enough about.
Yeah,
I definitely agree with that. I echo what Mark said, what Eric said. There is no way to deal with that overwhelming anxiety, that it's a stomach churning fear. And I really don't think there is any way to deal with it. However, what I've learned over the last 35 years is, on the good days or the good times within a bad day, try and do something. Get out there, even if it's just for a walk, take your dog for a walk. Even if you're anxious being away from your house, if you walk to the bottom of your street and back and just breathe in some fresh air, it just reintroduces these small little pockets of normality. And I think that is what helps to keep you going. Mark, like you, for many, many years, life stopped. I didn't go anywhere. I didn't leave the house. I was scared to even go to the supermarket. Those were the days when I was using sumatriptan. I would have oxygen in the boot of my car, and I would time it. You know, I tried to get a parking space as close to the entrance, and it was beginning to consume my life. You know, nothing was spontaneous in cycle. Everything had to be planned if I left the house. So then you would say, well, you know what? I'm not going to leave the house. And then it spirals. So really what I'm saying is, on the good days or in the good short times in a shitty day, get yourself out there. You'll be amazed at what it does for just your self-confidence, even if it's just for a short time. It's like a little bit of therapy. It gives you a little lift. So that's how I deal with it.
And Kyle asks about, does the environment or seasons play a role in cluster headache? And as was touched on Thursday evening, spring and fall are a bit more common for people to go into cycle for the episodics. But you could go into cycle at any time. You never think you can totally predict the beast. And that sort of seasonal cycling is a sort of circadian, maybe that's also can be termed circadian, although we have an expert in circadian rhythms who could comment on that further. I think so Mark, can I use the term circadian for a seasonal variation?
I think circannual is sometimes what people say for a yearly cycle. But yeah, I don't know what seasonal would be.
And you talked about on the, was it a dozen or 13, 14 genes that have been linked to circadian rhythms? Are there any genes associated with these much longer cycles?
We don't know. So some people thought thyroid, because in animals that have kind of mating cycles, the thyroid stimulating hormone, the thyroid hormones go up and down. So maybe thyroid, but no one really knows about these longer things. It may just be related to kind of light cycles, but that's our best guess.
If you take the person, so if somebody moves from the north to the southern hemisphere, actually that won't work so well, because when it's fall in one, it's spring in the other. So, but if you remove the seasonality, maybe at the equator, do they still get these bumps?
It's a good question. I don't think anyone studied it, except with the one exception. There's a group in northern, I think, Norway that tried to study it, and they had some cycling, but not a lot. I have had patients, and people here probably have stories where they went on a trip. I had one patient went on a trip up to Alaska and got a cycle once they went up there.
But you also, yeah, they also have.
They went air flight and everything.
Seasonal. They have a.
Oh, guy.
You're right.
So you wonder what is the trigger for, and that would be a way of finding out. So if anybody knows, let us know. If anybody has gone into an environment that doesn't have seasons or much different, and what happened to their yearly pattern. And Jessica says that I'm a person with an atypical headache syndrome, somewhat like hemicrania continua. So I imagine you're strictly one-sided, and you say you have significant autonomic features. I presume that means one-sided autonomic features, which puts you into the ballpark of hemicrania continua, but little or no response to indomethacin. The term hemicrania continua strictly is defined by the complete response to indomethacin, but the reality is not everybody does respond.
So, Dr. McGeeney, this case sounds pretty familiar, doesn't it?
Indeed, it does. Indeed, it does.
I would like to say that it says, "Is there a plan to include us outliners?" That's what I'm hoping to do, and I want people to start seeing cluster headache as not just episodic or chronic, but actually a spectrum. So
I refer to this as a plus syndrome, the CH plus syndromes. So you can either you have a lot of shadowing on that side, or a hemicrania continua picture. You see, the most common thing to have associated with cluster is migraine, but you generally don't have a blend, or it's not, that migraine is typically not strictly one-sided and is easily separable. But this is sort of a chapter that hasn't been really pieced apart. So Jessica, you know, that Wes is like this, absolutely. So you are welcome, you are quite welcome to the group. You see,
and
not everybody.
You can talk to me anytime.
So there are folks, even one or two folks who have the SUNCT syndrome or paroxysmal hemicrania, which is not exactly cluster headache, and they come to the meeting as well. Okay, Donna, I'm not sure what that is, the Beatles, but whatever. And Jessica, to all pro tip, psilocybin with VR headset. Yeah, that would be good. Yeah, that's a large dose of LSD plus a VR headset. That would be in some area where you cannot do harm to yourself. Do you have to come off verapamil to give psilocybin a try? As you know, this is an extremely common question, and the answer is, well, of course, we don't have evidence-based medicine to guide an answer, so you're left with anecdotes and what people do, and you will find people who are still on some verapamil who do bust. And I do believe there are people who do that and still get effect. So ideally you want to reduce it, but I don't think it blunts the psychedelic experience, and it may not really blunt the cluster effect. Any board want to comment?
Hey, Doc. I do want to suggest something. I know that Cluster Busters on their website has some interesting information about medicines and how they may affect the busting. Also, they, of course, have a message board where you can ask around. I know that I was taking something once that may have been affecting, I was using 5-MeO-DALT at the time, and there was concern it might be affecting it. So when people have those questions outside of the meeting, I highly suggest the Cluster Buster website and message board.
Gotcha. Thank you. That's an excellent comment.
Well,
And
the cluster headache studies that we're doing and migraine, we didn't restrict verapamil, so people who are on a steady dose and had been on it, we let take part in the study, and so there weren't a lot of people on verapamil, but I didn't see it have a major effect on the treatment.
And Emmanuel, was that decision made in an effort to increase recruitment, or with an understanding that it was unlikely to blunt a purported benefit on cluster?
I think the main reason was that we thought it'd be cruel to have people come off of the verapamil, and we didn't see any obvious safety issue in terms of if someone is on another serotonergic medication, we didn't feel as safe, but we didn't feel that there were major safety issues.
Yeah.
So those were the main factors.
Yeah, that's a good answer. It's a very good answer. Is there a reduced effect of mushrooms if you take them and go to sleep? Well, again, it should be probably one of the panelists who answers.
Well, it's typically hard to sleep
I
when
was
you're
going to say,
on
yeah.
mushrooms.
You won't be going to sleep. You won't be doing much sleep, I don't think. Less than you might think after a good dose. Isn't that right, ladies and gentlemen?
Yes, they're activating.
Hmm.
Psilocybin's activating, as is LSD.
Yeah, and maybe LSD even more so.
Yeah, yes.
So don't think of going to sleep.
Yeah, I don't think you're going to be going to sleep.
Well, since we were using relatively lower doses in our studies, we did have a couple of patients who fell asleep for much of the test day, and that didn't seem to affect their therapeutic response. But yeah, I think in general, people aren't going to go to sleep.
There'd be some dreams. And Brian asks, has there been any research or studies on daily microdosing with LSD or psilocybin? Well, Brian, one of the ways of answering that is to go to the clinicaltrials.gov and plugging in the correct spelling for psilocybin or LSD. And I'm teasing. And you can see, and then start to whittle down the studies that were registered. So that isn't a complete list of everything going on, but it is rather comprehensive because you heighten the importance of your study by registering it beforehand. And these days, a lot of journals won't even publish your study unless you've registered it beforehand, because it reduces the amount of shenanigans that can go on with clinical studies. Now, formerly, there were no studies, and is there one or two observational uncontrolled studies, or there might be some retrospective studies? What do you know about board? Any comment from the board?
I've had several patients reach out to me and tell me that they've been taking small doses every few days, as a preventive. But I don't know of studies.
Yeah, I don't think so. But this got a bit of media attention in the last few years, and there is a concern with the microdosing of LSD from the point of view of cardiac valves and the significant serotonin agonism. So the sort of receptor profile that it acts on is a little different to psilocybin. So psilocybin will be theoretically a little better. There is a very interesting story on that, but I probably shouldn't go into it. But it's go on.
Yeah, I'm also very concerned about the hype around. I don't like the term microdosing. I am concerned about the hype because people think that, oh, well, if the large dose is safe, then small doses more often must be safe too. But the way that psilocybin and other psychedelics have been taken for hundreds and even thousands of years is not in this manner. It's been occasional use of moderate to high doses. And the drug is gone from your system, within a day. Taking small doses, I don't know if it builds up in fat tissue. this is not the way that time has actually tested these substances, and I don't feel comfortable saying, oh sure, go ahead, the large dose is safe and the small dose every day must be safe too.
Yeah, yeah, no, thank you. Mark Benny asks, do prescribed opioids have any benefit in managing the unbearable pain? And I haven't really heard much. The reason you haven't heard much about opioids is, fortunately, it has no role. They have no role. But aren't they strong pain relievers? Absolutely. They absolutely are. It's just, we have failed to demonstrate or even conceptualize a good use for them. You end up being grasping in desperation and becoming opioid tolerant, and it doesn't much reduce your suffering, not much.
Doc?
Yeah.
Can I add to that? I am on opioids every day, have been for years, for my kidney stones. I curse them every day. I think they make honestly, I think it actually hurts the cluster headaches overall. I don't know if it's because pain receptors get changed or what. It certainly does nothing, if anything, for the cluster headache pain. I really want to encourage people who think about going the opioid use that it actually could make things worse. And I know we want to try everything, but as someone who takes it a lot, I absolutely despise them for cluster headaches. So just a thought.
And I'm sure there are nightmare stories among the community who have. I mean, it's probably the most dangerous thing we're talking about in this meeting are the opioids. And, thousands of people lose their life every year to the misuse of opioids. So it's far and away the most dangerous thing we're talking about. Fortunately, it really doesn't have much of a role. You see, for cluster is it's a short-lived onset, so quick. You'd have to be totally whacked with opioid. You'd have to take a non-oral route, and it'd be difficult to titrate. Thing about the nasal ketamine is, even if you put yourself to sleep, you generally doesn't stop your breathing, whereas opioids do. Hence, overdoses die. That's not to saying that you don't want to take too much ketamine either, because you could always kind of block your airway and suffocate. But it's in much safer than opioids.
I will add that I've used opioids for the constant pain that I had, the occipital neuralgia or the hemicrania continua, before getting the stimulator, and I was on high doses before getting the stimulator, and now I'm not. So I will say that they play a role, but not for cluster,
Yes, yeah, and that was the question. That's the question for cluster. I take your point. So Tom says a chronic ear. Yep.
Eileen just gave me the 5-minute warning. So,
okay. So you just tell me when to stop, and we'll stop. So Tom, and I've been taking them in order. I'm sorry, because there are 48 more or 50 more comments, I think. Tom says he's been chronic for many years, but the start of the spring and fall seasons seem to increase intensity and frequency. Yep. So my line is, I think even most chronics cycle. So they cycle to more frequent and less frequent. And I do believe that's common. And Roger's another comment. No problem getting oxygen in Spain. That's great. That's very good. And Kristen psilocybin, is it possible for a patient who chooses this alternative not to have any sort of effect or reaction to the psilocybin? Yes, if you take a small enough dose. You can certainly take a dose when all you might feel is a little medicated effect, but nothing of any concern, and certainly not a psychedelic effect. And you can still get an effect on cluster.
I knew a gentleman that could take it, eat it like candy, and never felt a thing. So it is possible not to feel the effects.
I think what you're asking is it possible for a patient no effect and no sign, given that the exact same and another person? Yeah, so there's a lot of individual variability. when some person is really affected by it and others not. Part of that, it might be it being broken down too much in the stomach and the body doesn't get infect much. But there are other reasons as well. Drug interactions, blocking from medications blocking the effect. So there are many reasons for one not having a response and somebody else using the same batch have a potent response. And Elizabeth says, I didn't attend all sessions, but I heard about the Botox study in Norway, injected not at the forehead, but in the eye or something. Do you know anything about that, or if it's going to be a future treatment regimen? I think that's registered in clinicaltrials.gov. And it's, I think it's an injection of botulinum toxin into the sphenopalatine ganglion, which is the ganglion up your schnoz, up your nose. And the Botox administered like migraine has no role whatsoever in cluster, nonsense. So if you're injecting it on the face, as are typical with migraine, absolutely not going to help. But this is a little different. This is injecting it into a collection of nerves, which is quite important, but not essential. Reasonably important, but not essential in cluster. That's the one botulinum toxin study that I'd be curious to see what happens. I'm just curious. It's safe. It might be a little uncomfortable, and I still think it's going ahead. It's going on. I haven't seen any results from that, but I would look for non-invasive options first, although it sounds pretty safe. And Tony again says, how are we for time? So I need, you just tell me when to stop and we'll stop.
Eileen said this will be the last question.
All right. So Tony has the last question. Our medical system, this is in Finland, eventually covers all oxygen if you can pay out of pocket to reach the roof amount. Okay. So you have a deductible, so to speak, which is a few $1,000s. Ooh, nice. So you have to pay out a few thousand and then they pick up the tab. Very few are able to do that. Ouch. This bothers me since I remember the times in the 90s when you're able to get oxygen gear from your local hospital for free. It's also illegal for you to lend my paid gear to someone who can't afford it. God forbid, it might help somebody. I may do that anyway. Oh, that's rotten luck. So with that being the last question, I'm sorry, but there are 50 more. I think we have to wrap it up.
Yeah,
folks?
I saw some, Jessica, you wanted to get a hold of me. I'm in the big group on Facebook. It's just Wes Helms. So you can contact me there.
Thank you all.